And I am a consultant psychiatrist in our neurodevelopmental service in Sussex. We are a interesting service in that we diagnose autism, ADHD, and Tourette syndrome, and actually increasingly all three at once in some of the assessments that I do. I actually trained as something called a liaison psychiatrist, so my interest is in the brain and the body. So I spend 2 days a week in the NHS and 3 days a week at brain body neuroscience at the Brighton and Sussex Medical School, where I lead a program of research that is primarily about something called hypermobility, which is where I started, and I will tell you a little bit more about that. I'm the chair of the Royal College's Neurodevelopmental Psychiatry Special Interest Group, and also a patron of two charities for neurodivergent people called one called SEDS Connective, which is about hypermobility and neurodivergence, and also ADHD Aware UK. You may have seen the news this morning, just as we knew in autism about reduced life expectancy, finally this has also been demonstrated in ADHD. So let's move the slides forward. So I hope not to overwhelm you with data today, but the idea really is to impart the big idea, to go through a recent brain body paper, predictive processing paper that we did on emotion regulation, and then really use that as a stepping stone to explain some of the bench to bedside work that underlies that, implications, and hopefully we will have a discussion. I wonder why my computer won't load the next page. So I stole this from Ed Bullmore, immunopsychiatrist. The big idea: should we drop the distinction between mental and physical health? The current false dichotomy holds back research and stigmatizes patients. I think it doesn't just hold back research or stigmatize patients. I think it holds back clinical practice too. So often we are siloed, so both siloed in terms of psychiatric services and medical services, but also even within the trust that I work, which I think is actually quite good about it with its neurodevelopmental service, we are completely siloed from the rest of mental health services, and we really need to bridge these silos. So I'm going to talk to you about a paper that we have published recently in the Transactions of the Royal Society B, in a special issue called Sensing as Being. So we know that emotional states are linked to the physiological state of the body, that sensing and feeling are inherently coupled. Now, work that colleagues Sarah Garfinkel and Hugo Critchley have done really shows that these idea of prediction errors, so the sort of difference between what you think is happening in your body or what you expect to happen in your body and what actually happens, are shown to be related to anxiety, and particularly with autism. This is something called interoceptive trait prediction error. And my colleagues, Hugo and Sarah and Lisa Quat, delivered a interoceptive intervention called AD, which reduced anxiety in autistic adults. And emotion regulation is an interesting but often neglected part of the neurodivergent emotional experience. So it doesn't feature in either the diagnostic criteria for ADHD or autism, but is actually very, very important, and one of the most troublesome. Dysregulation is one of the most troublesome features. But what we know is that we really don't know much about individual sensory things and their impact on feeling states. So I was interested in proprioception. So this is the sense of where you are in space. And we thought that hypermobility, which is this condition that I've been researching since 2009, may actually be a really good example of how uncertainty about sensation could in fact lead to emotional dysregulation. So this is the paper, and what we found, we had about 182 people. They were actually sampled for a different study, and you'll see why in slides further down the line, about chronic pain and fatigue. So half of the sample were purposefully sampled to experience chronic pain and fatigue, and half of them weren't. And what we found was that the hypermobility score, the emotion dysregulation, which was actually dissociation, neurodivergent characteristics, which was both ADHD and autistic characteristics, and proprioceptive surprise were all very highly correlated. We put this all together in a moderated mediation model. And as you can see, neurodivergence is linked to emotion regulation difficulties, and this is mediated by proprioceptive surprise. So proprioceptive uncertainty provides a mechanistic potential link between neurodivergence and emotional experience. And then, as you can see on the left, this is in fact moderated by the presence of joint hypermobility. So the effect is more than twice as strong if there is joint hypermobility. So you're probably, I mean, you may be aware, what is joint hypermobility? This is just a graphic depicting obviously hypermobile joints. So that's something like a child sitting in the W position or an adult doing that sort of yoga pose. But really, hypermobility is not as dramatic as these pictures might suggest. And really, the joints are a bit of a red herring. So hypermobility is far more than just having flexible joints. It's a difference in connective tissue. And connective tissue is a sort of cling film that is throughout the body. It's actually relatively common. So it depends whether we're looking at hypermobility alone or symptomatic hypermobility, so hypermobility with symptoms, but it can be advantageous. So, for example, there are piano pieces that can only be played by hypermobile fingers. Some of you may have watched the Olympics over the summer. Simone Biles is an excellent example of a neurodivergent hypermobile person, ADHD and hypermobility. It's linked to a variety of medical issues which cross systems and involve both the body and the brain. And I would say, as someone who's been in the field for a while, one of the major obstacles that we have is the nomenclature, so the language and our classification and screening tools is like alphabet soup. There are so many different acronyms that basically relate to hypermobility that it becomes so confusing. So there's GJH, GJL, JHS, EDS, EDS, HT, EDS3, HEDS. And you see it just goes on, and it actually means that it's quite a Baton scale, Brighton criteria. It's really hard for a single common message to come across, and there's quite a bit of confusion. Now you can see from this table that hypermobility is associated with medical problems across all systems. So something that seems relatively innocuous but actually can have a big impact, like flat feet, fibromyalgia, soft stretchy skin with stretch marks, hernias, gum inflammation, easy bruising, resistance to local anesthetics, a whole host of gastro problems, so gastritis, reflux, dysphagia, Crohn's, ulcerative colitis, irritable bowel, varicose veins, Raynaud's, very important when you're prescribing stimulants, irritable bladder, urinary stress incontinence, dental, ocular problems like myopia, so short-sightedness, strabismus, squint, dental pains, temporomandibular joint pain. And then where I came in, this idea of dysautonomia, so abnormalities of the autonomic, or rather the involuntary nervous system, things like dyspraxia, hyperesthesia, which is sensitive to pain, hyperosmia, sensitive to smell, and hyperacusis, sensitive to sound. You can kind of see how these are things that you may actually see in your autistic patients. Okay, so this is postural tachycardia syndrome, which is something I definitely didn't learn about at medical school. Postural tachycardia syndrome is a autonomic nervous system condition where your heart rate rises by about 30 beats per minute on standing. Can be tested for via a tilt table, which is what's shown here, or an active stand test. And phenomenologically, the symptoms of postural tachycardia overlap with the physical symptoms of anxiety. So things like palpitations, dizziness, and lightheadedness. And for the more physiologically minded amongst you, you will understand that if you have floppy connective tissue in your vasculature, so in your blood vessels, if you go from lying to standing, there is less return to the heart, so blood pools in the feet, doesn't get to the head. You might get brain fog, and the homeostatic mechanism to keep the body perfused is to raise your heart rate. Also, postural tachycardia syndrome, the symptoms can be provoked by hot environments and also a large meal, and it's all to do with blood volume shifts. Okay, so I did my PhD between 2012 and 2016 on how you get from having flexible joints to being more likely to have a panic attack. So if you take a room of 100 people with panic disorder, about 70% of them are hypermobile compared to 20% of the general population. The first study I did before my PhD, in fact, as an academic clinical fellow, we took 72 people, we divided them into a hypermobile group or not, and we did structural brain imaging that showed bilateral differences in amygdala, a part of the brain involved in fear and emotion processing. We also showed that the greater the hypermobility score, the smaller a part of the brain that's involved in representing where we are in space. But interestingly, and this was, we did this analysis in 2009, it was published in 2012, we saw structural brain imaging differences that had also been seen in autism and ADHD, particularly in superior temporal cortex and I think fusiform area. So we wrote back in 2012, our findings suggest that the processes compromising function in neurodevelopmental conditions may occur in individuals with hypermobility, putatively enhancing vulnerability to stress and anxiety. We followed this up with a look in the ALSPAT birth cohort where we showed that 14-year-olds who were hypermobile were more likely to experience anxiety and depression at 18, and that for the males there was a mediating effect, so a possible mechanism in terms of high heart rate. We have this paper right now, it's in press with BJ Psych. It's a functional imaging paper about hypermobility and anxiety. And what we have shown is differences in amygdala and insula. So the amygdala, as I said, is responsible for fear and emotion processes. Insula is interoceptive, so that is the internal sense of what is happening in the body. So we conclude that the predisposition to anxiety in people with variant connective tissue, i.e. hypermobility, reflects dynamic interactions between neural centers processing threat, the amygdala, and representing bodily state, insular and parietal cortices. And my PhD, our PhD student who has drafted this paper, first author, she's actually doing a PhD in biofeedback, real-time fMRI biofeedback. So she was of the opinion that correspondingly interventions to regulate amygdala reactivity whilst enhancing interoceptive precision, that's things like the AD study that I mentioned earlier, may have therapeutic benefit for symptomatic hypermobile individuals. So you're probably, and I just want to say a huge thanks, particularly to Prof. Hugo Critchley, but Professor Sarah Garfinkel, Dr. Charlotte Ray, Christina Camporelli, the first author, and Poppy Grimes. So we used some of the data that came out of those studies that indicated that there was a difference in what was happening to people's heart rates and the symptoms they were experiencing to pioneer the development of an intersective and cognitive therapy called altering dynamics of autonomic processing therapy. And for that, I received an MQ fellowship. We have published the protocol. We completed the trial, which had to be radically adapted to be able to be done in people's homes during COVID. And we found that it was an effective treatment for anxiety. So thinking about hypermobility and anxiety has been a bit of a light bulb moment. And actually patients and members of the public write to me about how it is often a light bulb moment for them. We have written with our academic clinical fellow, Harriet Sharp, a review on connecting brain and body, transdiagnostic relevance of connective tissue variants to neuropsychiatric symptoms. And with Dr. Chich, we have written about how hypermobility and these symptoms of postural tachycardia are associated with multimorbidity at the intersection between physical and psychological health. And as I said, we were thinking about the curious similarities between hypermobility and autism and ADHD. And that led me during my PhD to collect data on hypermobility, ADHD, autism, Tourette syndrome, and physical symptoms related to orthostatic intolerance and pain. So what do we know about autism, ADHD, Tourette syndrome? We know that gender stereotypes are complex and a challenge, that having thought that this was a condition that predominantly affected boys, that is not the case, and that many key elements are not well captured by the diagnostic criteria. For example, the role of variable attention and emotion dysregulation. And what we know and what we encounter in our clinical practice is that co-occurrence is the norm rather than the exception, both with other neurodevelopmental conditions and certainly physical health issues. In our neurodivergent brain body clinic, we have so many patients who all are experiencing pain, fatigue, dizziness, gut problems, and they are not served well by the current medical setup. So I just wanted to highlight this article that showed that if you give school teachers a vignette and ask them to put forward people for a possible autism assessment, they are more likely to do so if it has a boy's name on it rather than a girl's name. But in fact, that we're realizing that the the sex ratios are probably more equal than we thought. We also know that autistic people experience significant barriers to healthcare and self-reported adverse outcomes. So what are the commonalities between hypermobility and neurodivergence? Well, dysautonomia, so postural tachycardia, has been reported in both. And actually, when I was doing my PhD, there was quite a lot of interest in, was there a shared abnormality in the noradrenaline transporter gene that predisposed to both POTS and ADHD? That hasn't actually come to anything significant, but what is interesting is ADHD medicine is used to treat POTS off license in America. It's vasoconstrictive stimulants. Both conditions report pain, though interestingly, when we published on pain in ADHD and autism, someone on Twitter said to me, but this can't be possible. Autistic people don't feel pain. Dyspraxia, so there's coordination difficulties. Anxiety is common to both. And there were some case control studies in children showing overrepresentation of hypermobility in ADHD and dyspraxia. And then as we were doing this work on hypermobility, autism, and ADHD, the Swedish registry people published a very interesting study with their national database suggesting that symptomatic hypermobility was associated with an increased likelihood of autism of 7 times, an increased likelihood of ADHD of 5 times. Separately, Carolina Bieza-Velasco, a Chilean researcher based in France, was looking at ADHD, hypermobility and pain, and also autism, hypermobility and pain. So what we did is we put all of this together and we published this paper, Joint Hypermobility Links Neurodivergence to Dysautonomia and Pain. It's very popular, I think, with the patients, more so than other doctors who still seem a bit nonplussed about hypermobility. What we found was that if you were in our neurodivergent group, which were 110 patients with diagnoses of ADHD, autism, and Tourette's and combinations thereof, you were 4 times more likely to be hypermobile than the general population or our comparison group. And as you can see, the neurodivergent patients had considerably greater musculoskeletal symptoms and symptoms of orthostatic intolerance. They also had a higher Baton score. Looking here in the kind of pale pink, you can see that nearly 80% of patients, autism and ADHD, nearly 80% of them hypermobile, and that the hypermobility scores tracked with the orthostatic intolerance scores and the pain scores. So putting this all together, as we did with the proprioception, looking for mediators and moderators, a mediator explaining the process of a relationship, a moderator affecting the strength and direction, we found that being neurodivergent was associated with physical health symptoms because of hypermobility. And this really means that I think we all need increased awareness. So if we are seeing someone neurodivergent, we should think about hypermobility. We should think about neurodivergence in someone with hypermobility. And I've often talked about this, and people write to me and they've said, well, this is all very well, improved screening, but we really need to consider, are our services, particularly pain clinics and things, are they accessible and friendly? And this is a genuine consideration. So I'm going to talk a bit about some perplexing symptoms, pain and fatigue, some of the most common things that present to GPs. This is a study that we did that was funded by Versus Arthritis. We were hoping to find a number of fibromyalgia patients who only had pain, ME/CFS patients who only had fatigue, and some that had both. And we conducted 2 experimental challenges. One was bringing them into our clinical research facility at the hospital and putting people on a tilt table, and the other was bringing them to our university brain imaging center, and on 2 occasions. And on the first occasion, well, in a double-blind randomized crossover way, on one occasion they received a saline injection, and on another a typhoid vaccination. So this was a study, we called it the Mechanisms of Chronic Pain and Fatigue study. We found that although a third of the patients had a diagnosis of fibromyalgia and a third had a diagnosis of ME/CFS and a third had a dual diagnosis, that they in fact pretty much all met diagnostic criteria for fibromyalgia. Fibromyalgia is a chronic pain condition, ME/CFS is a chronic fatigue condition, and they pretty much all met diagnostic criteria for ME/CFS. But interestingly, fibromyalgia and ME/CFS are quite tricky clinical diagnoses, whereas hypermobility has a number of kind of biomarker elements to it. And we found that a now defunct term, the Brighton criteria for joint hypermobility syndrome, nearly over 80% of our fibromyalgia and ME/CFS patients in fact met Brighton criteria, and that the hypermobility features correlated with fatigue, pain, and brain fog. We also found that the patients had mildly elevated baseline inflammatory bloods, so ESR and CRP, which are both kind of blood tests that GPs can do. But as you can see here, there's clear water between the patients and the controls, but the patients are basically sitting at the edge of what is considered the reference range. We found that these markers of inflammation correlated with fatigue severity and pain level. And the tilt table meant induced pain in the patients compared to the controls, induced fatigue in the patients compared to the controls. And interestingly, we measured pain thresholds, and people often think that fibromyalgia and other conditions are to do with central sensitization, and that it isn't so much about the amount of pain, but the pain signal. We found that there was no change in pain threshold induced by tilt, and so this would suggest that the autonomic challenge is introducing greater pain. So as you know, I'm fond of these mediators and moderators. We put it all together, and being a patient with fibromyalgia or ME/CFS is associated with tilt-induced pain, and that is mediated by joint hypermobility. And being a patient is associated with tilt-induced fatigue, and that is mediated by baseline level of inflammation. Now, we brought them into the brain imaging center. And in the brain imaging center, we measured pain and fatigue, and we did brain imaging. But as I said, almost all of the patients had hypermobility. So we bore down into one particular feature of hypermobility, which is long spidery fingers, a key to diagnosing the heritable disorders of connective tissue, arachnodactyly. And we found that if you were a patient, you were more likely to experience inflammation-induced pain and fatigue. So pain and fatigue as a consequence of the inflammatory challenge, and that this was mediated by your inflammatory responsivity, but only, that relationship only held if you had this particular hypermobility feature. So this, I mean, there's other work, transcriptomic work, brain imaging work, we could talk about it all day, but this was a huge piece of work, and I must say thank you to all of the people involved, but particularly our chair of medicine, now retired, Professor Kevin Davis, the rheumatologist. So the work that we were doing on fibromyalgia and ME/CFS made us interested in long COVID. And I gave a talk, I think it must have been in 2022, at a long COVID workshop in London. And the talk after me was by a woman called Professor Claire Steeves. And she had been part of the group that had used the Zoe app during COVID to collect COVID data. We now know of it as a diet app, but it was briefly repurposed to collect COVID data. And she said, why not introduce some hypermobility measures into our next data tool, which we did. And we found that if in 3,000 people who'd had COVID, we found that if you were hypermobile, you were less likely to recover from COVID. But you weren't more likely to catch COVID. But you can see in the COVID recovered group, about a fifth had generalized joint hypermobility, whereas nearly a third did in the COVID non-recovered group. And when we put in, number of covariates, age, sex, ethnicity, socioeconomic status, education level, vaccination status, number of vaccinations, this relationship remains significant with an odds ratio of 1.3. We have now actually, that was a predominantly white and female sample, and we have under review a paper that has replicated that in a more representative sample. And we found that the relationship between hypermobility and long COVID was likely due to joint hypermobility. So what does this mean? People with hypermobility, an index of variant connective tissue, are approximately 30% more likely not to have recovered fully from COVID. This observation is clinically important through its potential impact for understanding and identifying a sub-phenotype of long COVID. So this is a type, so about 70% of long COVID patients develop POTS, maybe they're the hypermobile ones. More generally, greater awareness of joint hypermobility and its non-joint manifestations is needed for effective patient stratification and implementation of personalized medicine. Where are we? Why won't it go forwards? So, what is the relevance of autism and neurodivergence to chronic pain and fatigue? We looked in the ALSPAT birth cohort at children aged 7 and 9 for autistic and ADHD characteristics, and those with likely autism and likely ADHD, both of them twice as likely to experience chronic disabling fatigue at 18. And this was mediated by high levels of inflammation. So the marker IL-6 at age 9. Our results indicate that we should think about transdiagnostic screening to inform support strategies to counteract risk early in life. So by identifying neurodivergent children and supporting them appropriately and managing their mental and physical health problems, we may avoid chronic disabling fatigue at the end of adolescence. So why is it important to think body-brain? Well, nearly half of neurodivergent individuals surveyed by Embracing Complexity felt that their treatment of mental or physical health symptoms was worse because they were neurodivergent. And our previous patient and public involvement work tells us that patients struggle for years to get an assessment and diagnosis for both mental and physical health problems, feel a strong sense of being dismissed, misbelieved, or overlooked interacting with professionals and institutions, and repeatedly encounter poor understanding or few or no adjustments. We also know, and this is thinking back to the proprioceptive surprise study, that conventional emotion or medication-based treatments do not work for all, and targeting things like proprioception may in fact open up opportunities for novel avenues for personalized body-based treatments for common mental health problems. Oh, sorry, the slides won't move on. And the traumatization is real. People wait for years for a hypermobility diagnosis. So you can see when you take that into consideration with neurodivergence, the double disadvantage. And of course, we are also working on some strengths in the neurodivergent hypermobile body. And hopefully we will be able to talk about that more when this is published. And we have some exciting projects going on at the moment, including brain fog, where we're using a lower body negative pressure chamber to simulate tilting in the brain scanner, use of flotation tanks to improve fatigue, and we're looking at brain fog in pregnancy and the menopause. So I have to say a massive thank you to all of the team, but particularly Hugo Critchley.